short presentation, I will say a few words about orbital volume. I will emphasize the importance of orbital compliance, the discrepancy between clinical findings and orbital imaging, and the importance of signs and symptoms outside the orbit. Well, everything in the orbit is about the volume. Human orbits are cavities, pyramidal in shape, with openings on the base of that pyramid. Well, actually not closed, because they're not closed, not open, because they're actually closed with dense and firm fibrotic tissue that presents a base suspensory base for upper and lower eyelid, which are holding the globe and orbital content within. When we talk about orbital volume, we haven't gone much further from the discoveries that were made 50 years ago. So, regarding the analyzing of normal orbital volume. So we are estimated that orbital cavities can contain a volume of around 30 cc's. That globe will take 7 cc's, and the rest will go for extraocular muscles, lacrimal glands, orbital fat, neovascular structures, and fibrotic tissue. All these structures are well organized and forming orbital compartments. So, unlike the other fields in ophthalmology, no fancy diagnostic tools here. Only me and myself. Well, with a little help of imaging methods, namely MRI and CTs, which can give us information of morphology of the process, and in recent years development of DWI and ADC maps, giving us insights on certain physiological changes in orbital tissue. We can define almost all orbital lesions as space-occupying lesions, which will create volumetric and functional impact, whether they're inflammatory diseases, namely thyroid-associated orbitopathy, IgG4, orbital cellulitis, orbital abscess, Deluva-Hunt, sarcoidosis, GPA, fibrous dysplasia, etc., whether they are proliferative conditions, primary and secondary, malignant and benign tumors like lymphoma, rhabdomyosarcoma, neuroblastoma, hemangioma, hemangiopericytoma, etc., whether they are congenital conditions like tumors, vascular malformations, developmental anomalies, or the impact of trauma with accumulation of air, blood, or foreign bodies. I mentioned at the beginning the importance of orbital compliance. What is orbital compliance? Orbital compliance is the amount of repulsion that can be obtained by pushing the globe and normal orbital structures within the orbit. If the patient has firm and dense connective tissue, it is most likely to expect that the orbital compliance will be low. On the other hand, if the patient has loose and elastic connective tissue, orbital compliance is likely to be higher. So why friend or enemy? In the case when we have orbital space-occupying lesion, good orbital compliance will at the beginning alleviate visible signs and may delay establishing the diagnosis. On the other hand, it will also decrease the risk of compressive effect of this new volume burden on optic nerve and normal orbital structures. Conversely, bad orbital compliance or low orbital compliance will at the beginning allow more abrupt, more acute visible signs, which may facilitate the diagnosis, but at the same time it will decrease the pressure on the optic nerve and normal structures leading to visual threatening situations. So in the next few slides, I will show my patients with most common orbital disorders and different clinical presentations. So the first slide being a number of patients with the same diagnosis, but as you can all see, very different clinical presentation. It is very nice when we have a typical patient, when the diagnosis is straightforward, but sometimes it is not the case, and we have lots of difficulties to make a diagnosis. So here we have a range of signs from ptosis leading to globe subluxation, which you can see.